Thank you very much for calling me to this debate. And I hope you can all see me better this time compared to my previous talk yesterday. So I am a big proponent for staged hypospadias repair. Can we just go back to the first slide, please? Okay, I'm able to control things. So I'm a big proponent of staged hypospadias repair, and probably it is partly because of the way I was trained, and also partly because of all the patients I see with various complications. Now, when we see complications of some technique, it does not mean everybody gets those complications. There is definitely a small number of patients who will get complications from any procedure. But how we deal with those complications and how difficult it is to correct them, that molds our thinking about which procedure we want to choose in future. So my presentation is going to talk about how do we choose this proximal hypospadias with Chordee, which repair do we choose, and that will be dependent on the severity of the various components of this hypospadias. That is, how severe is the Chordee, is there an associated torsion, and so on and so forth. And what method we use to repair that, even within the stage. So I'm going to talk only about stage. So within that staged repair, what are the methods we can use? What are the overall results and immediate complications? And I specifically want to talk about late complications, and specifically two things, that is megalourethra and recurrent Chordee, cosmetic results, and then parent and patient satisfaction. I'll just try and cover as much as I can within these 5 minutes. So my preferred technique for staged hypospadias repair is actually a BRCA1 repair, where we're using a free graft, a free full thickness graft from the inner preputial skin. So, I don't know. So this is a child who's having a very severe Chordee. And you can see how bad the hypospadias is, and very short urethral plate. And unless we actually divide this urethral plate, we are not going to get correction of this Chordee. So this is where we have done as a BRCA1 repair, and you can see how much correction of the Chordee has been achieved. And this is what I do for my second stage when I look at the results of the BRCA. So I want to see this straight, the phallus with a nice, supple, smooth graft over there. And this is how I'm showing at the time of my second surgery how the skin of that graft has become soft and supple. There's correction of Chordee, and then this is now suitable to go for a second stage. So correction of the Chordee is paramount before going for the second stage. And this is the same patient having undergone a BRCA2 repair, and I want to just concentrate and show what a nice glance repair that we are able to get in these situations. I went ahead and did an AI search. I guess everybody nowadays does this AI search. So, and this is what Google told me. It said staged repairs are generally preferred over single stage repairs for patients with proximal hypospadias and Chordee, because they have fewer complications. And I think it's not just the number of complications, because even in my hands, when I do staged repairs, I am anticipating a complication rate of about 30% to my patients, be it infections, graft loss, or a fistula, or whatever needs to be done. So all of those things, my complication rate is around 30% for a staged hypospadias repair for a severe hypospadias. But the systematic review has found that single stage repairs have got higher complications than two stage repair. They say that urethral fistula has got a higher incidence with single stage, but I don't think urethral fistula per se should be considered as a major complication with hypospadias repairs, because they are the most easily correctable amongst the various problems that can happen. Cosmetic and functional outcomes, both of them do provide satisfactory cosmetic and functional outcome, but essentially, at the end of the day, it all depends on whether the urethral plate can be preserved. Where the urethral plate can be preserved, you may be able to get a very good outcome even with a single stage repair. But when the urethral plate is divided, I think probably going for a proper grafting gives good results in the long term. So again, this is what AI says. When the urethral plate is preserved or transected is a key decision. And single stage repair can be successful when the urethral plate is preserved. Okay. Cosmetic appearances, I mean, these are the other factors that need to be considered by us when looking at children with proximal hypospadias, is whether you can preserve the urethral plate, how is going to be the cosmetic appearance, and how important that is to the parents in the long term. Single stage repair, the stage repair has actually got a shorter learning curve as compared to the single stage repair. And I think once you are a much more experienced surgeon, you may be able to consider for single stages in many patients. So I'm just going to give you some references from this. And this is looking at the long-term results of two-stage repairs in patients where we're looking at them after puberty. And this is 27 boys after two-stage hypospadias repairs, the mean age of 15 years we were looking at. And the meatal locations were in different places, but I think they all had severe chordee. So eventually the meatus would have receded back at least to the penoscrotal or more proximal. The average age at the time of the repair was 2 years. Additional surgery was required in 45% of the patients. All patients, they say, with the two-stage repair. So my additional surgeries are around 30%. So maybe I'm still underestimating. All patients have got a normal meatal position, normal glandular anatomy, well-defined coronal sulcus, and a very good cosmetic outcome. And of their long-term results, 40% have got minor spraying of the urine, all were able to stand up to void, but 40% are needing to milk the urethra after voiding. None of them had any residual chordee. I think that's very important for us to look at because I'll talk about that later again. And in terms of sexual outcome, 20 patients were able to ejaculate, and 9, that is 40%, had still had to milk the ejaculate also. And some of them, small percentage, had minor pain with erection. And again here, all subjects were satisfied with their urinary, erectile, and ejaculatory functions, and 92% were pleased with their appearance. And this is another paper, again looking at long-term outcome of severe hypospadias. We evaluated by HOSE and quality of life index. And again, they said that voiding abnormalities like spraying of the urine and all that were the leading symptoms that they had later on. Nobody had erectile problems and 11% had ejaculatory problems. Cosmetic outcome was satisfactory.
Can I interrupt, Dr. Laxmi? You have crossed your time because
Okay.
the time
I can continue with the second part later. Yeah. Oops, sorry. Can we close this? No? Okay.
Tony Mundy observed in his huge series of multiple stage repairs that he was extremely dissatisfied with the results. Meatus had receded in most of his cases. There was no spongiosum cover, no dartos cover, and there was a thin skin which was stuck to the urethroplasty. Now that is certainly not what the objectives of hypospadias repair was. So the goals of the cosmetic repair and the functional repair were not being addressed by multiple stage repairs, especially when it came to the location of the meatus. Then there was a phase that it would take a long time for anybody to learn. A systematic review was done where it was shown that even residents can be taught single stage hypospadias repairs quite successfully. The meatus location at the tip in single stage, in 98% of the times you are able to locate the meatus at the tip. Whereas in multiple stage repairs, on only 60%, and most of the time it lands up coronal and may need additional surgeries. So a second surgery after a single stage is required in only 10 to 30%, which are usually minor, just a fistula or a diverticulum or a stricture, which are easy to repair. That means 70 to 90% do not need a single stage, a second stage, which is a real benefit for all stakeholders. Here you can see severe hypospadias repaired, and the patient, after becoming an adult, has a very satisfactory result. Even when you have 8 centimeters Duckett's tube, which has been made, yet you can see the long-term results in a single stage itself very nicely achieved. When it comes to the residual chordee after a single stage repair, after a multiple stage repair in stage one, and that is the biggest drawback of multi-stage repair, that you think what you're excising in stage one is actually the corpus spongiosum, which we have proved histologically also. You think that it is chordee tissue. So isn't it possible to use that corpus spongiosum and the dartos which is available and use it as a cover on the normal urethra and try and restore the normal anatomy, and it is successfully done in single stage repairs only. So long term, a much neglected area, multiple surgeries are a definitive risk factor for poorer psychosexual outcomes, and this is proved as latest as 2020. In my own cases, all cases, more than 3,000 cases done in a single stage, most of them, very few multiple stage. And the incidence of a second surgery is only about 22%. That means the other 80% were cured in a single operation itself. Now, what is the benefit for the child? Single admission, single anesthesia, single instance of loss of playtime, and a much superior cosmetic and functional result, and a quicker restoration of the body image because you can do it really early. What is the benefit for the parents? Repair doesn't drag on. A two-stage becomes 3, 4, and even 9. Earlier the child is fully corrected, quicker are the parents relieved, and they are back to their regular activities. A single admission also means reduced expenses. What is the benefit for the resource poor government? Every admission is a cost to the exchequer. The total bed occupancy days, the total OT time, the total cost of medicines, everything reduces drastically. And it also deprives another deserving patient of the same facilities if you're doing it in multiple operations. What is the benefit for the pediatric surgeon? Few surgeons of other specialties will dare to do single stage reconstructive surgeries. That ensures that the bastion of these cases gets reserved for pediatric surgeons. So why lose the turf? Results of single stage repairs are any day better when one learns the nuances of the techniques. They are not at all difficult for the super skilled fraternity of our pediatric surgeons. A very important lesson for the juniors, planned single stage is aspirational surgery. Planned two stage is a compromise. To stay relevant in the long term, we have to stay ahead of the other faculties. So how do you capture the market? This is especially for the juniors. How do you capture the market? You have to think of what attracts a consumer. Undoubtedly, it is single stage hypospadias repair surgery. So what is the benefit for medical science per se? The thrills of learning new skills, perfecting them into surgical drills will go a long way in bringing frills, which fills the bills of the surgeon, who fulfills the desire of a child to rid him of his ills, which kills his yearning to point at will. So do all hypospadias in a single stage. We should, because we can. Yes, we can. Thank you.
So I will allow 2 minutes rebuttal to each of you.
And I'm very glad I stopped during my initial presentation, because then I can show you what happens in some of these patients who undergo a single stage surgery. It may be appropriate in certain people's hands, but we need to look at the vast majority of surgeons and how they are faring with these kind of repairs. Okay. Full screen, yeah, thank you. So this is what I was talking about as an acquired megalourethra. So we talk about these ducats, tubes and onlay flaps, and there are these patients who come to us with this acquired megalourethra after these repairs. I do grant that the numbers are not huge, and that's what I said in the beginning. Not everybody is going to get a problem, but when they get a problem, how do you correct that? And here is the same patient when he's trying to pass urine. He has this huge big bulge in this urethra. And this patient came to me at the age of about 5 years without any confidence. He was constantly dribbling, wetting his pants, and he was totally disgruntled with life. And we had to go and correct this along with correction of the fistula and then make this patient better. So not everybody has got a good outcome. Why is it not coming down? Okay, so this is how we managed to correct him. And this is another patient who comes to us. So that was not a solitary case. I see a lot of patients who come to us with this acquired megalourethra, and you can see how big the urethra that has been created. It's a whole pouch. And part of the problem is because we use the foreskin, particularly we use the outer foreskin in part to recreate that urethra, which has got enormous capacity for expansion. And it is not supported. Not everybody can have particularly when you've got a severe Chordee, you don't have enough corpus spongiosum to cover this repair. So this urethra that you have created is not supported, and that is what causes a megalourethra. Okay, why am I doing it wrong? Sorry. So this is again a study about recurrent Chordee in about 97 adolescents and young adults following childhood hypospadias repair, and this is from New York. And they would say that 13 patients were operated elsewhere, and the remaining 46 were operated by themselves. They have done it. Okay? And what they said, the majority of the patients undergoing, single stage repairs. So single stage repairs and dorsal shortening procedure, that is either the tip or the corporal plication. So 43 out of 46 patients who had recurrent Chordee, which they have themselves operated. And they, out of the 49 patients, out of the 46 patients, 43 had single stage repair. And only 3 patients had staged repair. Okay, and there's another study here by Snodgrass, who's a big proponent of single stage repairs, and they themselves have said that they have concluded that when there is severe Chordee, they have stopped doing single stage repairs. They will not do it because they will have a lot of these patients will end up with recurrent Chordee, and they themselves are saying perform proximal tip only when there is less than 30% or no ventral Chordee. And here is another one, case for a 2-stage repair with perineoscrotal hypospadias with severe Chordee, and they have also concluded. So what they have said is the cosmetic and functional results are excellent with the 2-stage as compared to the single-stage repair. And there have been many other papers where people have actually moved from a single-stage repair to a 2-stage repair because one, they are having complications, but also equally important, these complications are extremely difficult to correct.
Dr. Laxmi.
Thank you.
You are again crossing your time.
Thank you.
To our speakers and audience, this time was actually meant for the rebuttal. So Dasmit sir will present his points.
Thank you, Lakshmi. You made my job so much simpler. My worthy opponent was talking about how the second stage becomes very, very difficult. I'm saying it is still the second stage. Let it be difficult. It doesn't matter. It's very rare that it is very difficult and non-correctable. Still, it is only a second stage and required in only 20% of cases. What's the harm in that? When we start off, we tell the patient that yes, we may need to do a second stage, which is fine. But the second stage is so much simpler. Whereas you start by 2 stages, and Snodgrass, who my worthy opponent has indicated, he has gone into 3 stage. He is planning a 3 stage. And the reason is because of the wrong choice of surgery for the wrong kind of a patient. It's a pathological anatomy which dictates what kind of a surgery has to be done. So when we are able to give it a spongiosum support, even if partly or completely, it's very, very rare that you get a diverticulum. In my own cases, in 3,200 cases now, only 7% of diverticulum, 10% of fistulae, and just 2% of a meatal retraction or the glans opening up. Very simple to repair all these cases. So I would say go by the single stage repair, learn them, go by the single stage repair. Yes, if you get a complication, it might be 10% in my hands to 20% in somebody else's hand, or maybe 50% in somebody else's hand. But yet, the 50% that you have done in a single stage, you have still achieved a very, very big, overcome a very, very big problem. Thank you.
2 minutes for review.
Yeah. In my experience, when I'm offering a staged repair, for hypospadias, when the patient, the parents come to me for that repair, I tell them that I'm going to start thinking about 2-stage repair for this. It's quite likely about 1/3 of patients are going to need a 3rd stage. But I tell them the only thing I can guarantee and tell you is that at the end of all of that, your child is going to have a normal looking penis, circumcised, but yes, a normal looking penis capable of normal function. And I can guarantee that to you. And I don't have a single patient, I don't have a single parent who tells me, no, you have got to do it in one stage. They're completely happy and they are completely committed to taking their child through as many number of surgeries as required. I don't have a single patient who says, do it in one stage.
All my patients agree that they want it in a single stage. Maybe we are catering to a different population. We are catering to a different crowd. I do all my hypospadias repairs, diagnosed at birth, operated at 6 months. They are free of the whole problem. A child, the minute the child turns 1.5 years, his genital awareness has started, he's scarred for life. I don't want to leave it any single patient uncorrected at 1.5. Once I've done the first stage the first surgery at 6 months, the 20% who do need the next stage will be done after a year. So at 1.5 years, before the genital awareness starts, the patient is sorted out.
So we had done a recent study in one of my PG theses where I looked at cosmetic outcomes, and we did ask questions from both the parents and from the patient themselves when they are old enough to ask them questions about their perceptions and the genital awareness, whether they feel that things have gone out of hand during their various procedures. Almost all of the children don't remember their surgeries unless they were done much later on in life. So anybody who's had surgeries at 2 years, 3 years, they don't remember it. And the only problem comes when they are much older, say 8, 9 years. That's when you're going to do surgery and they would remember that. So I don't
we have
buy
to
that.
stop now, Dr. Dasmit. Yes, I'm allowing you 2 minutes.
So do I have a chance for rebuttal or that's it?
Now
Sir, another counter to the ma'am's rebuttal. So just one counter to the ma'am's rebuttal.
Okay, fine. I'll keep
It was an ongoing discussion.
I'll keep it very short. All the redos which I have done, that's a very, very large number. A large number of them were either secondary to Snodgrass repairs and people who attempted Snodgrass repairs for proximal hypospadias, which he himself did.
Which is single stage.
And that was a big, big mistake, which he has also realized. And the second types of redos are the ones who have undergone surgery multiple times, started off as planned, either single stage or multiple stages. But multiple stage does not guarantee that your Chordee will get corrected. And ultimately, it's a very compromised situation once the patient has undergone multiple surgeries. The functional and the cosmetic result is always going to be compromised. The psychosexual assessment can only be done in an adult. And in 2020, this huge paper which came out said that multiple surgeries is responsible for a poor, very poor psychosexual outcome. And that is also a reason why a single stage repair would be a much better way to do it.
I think we need to look at that paper to see what age the redo surgery was done.
please stop here. No more.
Thank you.
We are across the time. So it is my time to give the verdict. To me, truth is somewhere in between. Neither, because hypospadia is such a problem that it has no single solution. So truth is somewhere in between, and all the procedures have some utilities, and it should be based on selection of case. And that needs some experience with the surgery, and you gain that insight after, say, 5-10 years of doing a procedure. But to the youngster, I should advise they should know the few surgical procedures they should know, and they should try to master them and apply them as is necessary. So it is very difficult to give a verdict in between two stalwarts. I declare Dasmit as winner because he has never crossed the time. Laxmi has always crossed the time. That's my verdict. Thank you all for patient hearing.